Okay. Welcome everybody to the National Suicide Prevention Lifeline's March webinar. This webinar is the Crisis Center follow-up, Working with Emergency Departments and Health Systems webinar. And I'm so excited to have a few of our Crisis Center folk from North Dakota join us from FirstLink. We have Cindy Miller, Jennifer Illick, and Jackie Olson joining us from FirstLink, and I'm really excited, and I very much appreciate you all joining us. We also have Caitlin Peterson from the Lifeline who will present toward the end of the webinar. So FirstLink people, do you want to go ahead and take it away from here?
That would be great. Thank you. So a little bit about us. Here's our names, and people certainly can contact us if they have questions also. I'm Cindy Miller, the Executive Director at FirstLink.
I'm Jennifer Illick, the Director of Helpline Operations.
And I'm Jackie Olson. I'm the Suicide Follow-Up Program Coordinator.
And so our mission and vision at FirstLink is basically to be the first link in linking people and resources 24 hours a day. A little bit about, this is one of our follow-up program success stories, just so you understand a little bit about what we've been doing. Jessica's a teenage girl who's bipolar, suffers from schizophrenia. She has a client of domestic violence in her past relationships, and she's currently struggling with some different issues in a current relationship. On several occasions when we've made outgoing calls to her, she's expressed that it was perfect timing because she was feeling suicidal and needed to know that someone cared. We've been able to link this client with counseling services as well as mental health support groups in her community. So why we're doing this and how we do it is, obviously we believe in fighting the stigma of mental health issues and suicide through those services that we provide. And we do answer the 211 helpline for the entire state of North Dakota. We also answer the National Suicide Prevention Lifeline. We're part of that network. So, and we are the only call center in the state, in the entire state, that does either of those. We also do a lot of trainings on suicide and mental health so that we really, make sure that other people are understanding the training. And the follow-up calls are a great addition to our other services that we have that give extra support to people who are having suicidal thoughts or actions. Another follow-up story of success I just wanted to share with you is about Mark. He's a male farmer he lives in a small rural town in North Dakota. We have a lot of rural communities, and he has a wife and children. He had a history of suicidal ideation and depression with self-harm. He's strongly involved with his faith community in his town. However, he feels he can't confide in anyone in a small town, and anyone who knows, in a small town how things can kind of get around. So he's really nervous about that, and he doesn't want his children to find out either what he's been dealing with. So he'd recently been admitted to the hospital for cutting and suicidal ideation, but he's also expressed numerous times how thankful he is for those calls that we're making because he has someone to talk to that won't judge him and that doesn't know him in a small community. He has also remained in the program longer than the average person, and he's requested that because at this time he feels he needs the supportive contact of outgoing calls. About twice a month is what we've been calling him back. Since he was discharged from the hospital, he's been able to refrain from cutting and self-harm, and we've also been able to give him a national resource for an online support group community regarding self-harm and cutting, as well as making him aware of the services and resources that FirstLink and NSPL can provide for him. So this is just a little bit about our what we do today. Like I said, we answer the 211 helpline. We do have a lot of contract agencies. We have to answer after hours for them. We're part of the National Suicide Prevention Lifeline Network. With our suicide support services, we do have this follow-up call program. We do a lot of education outreach in the schools and in the communities, and then we're doing suicide prevention trainings also. So in 2016, we had almost 50,000 calls. Just so you kind of know about the size of us and kind of what we're doing. The total resources given out were a little over 18,000. Our calls related to suicide were 2,512. And suicide follow-up calls, you can see 1,150 calls were made in 2016. So, and that's constantly increasing. So the program is going really well. We only needed to contact dispatch and law enforcement 62 times on those calls, which does a lot for that listening and support that's done.
So in collaboration with SAMHSA and the North Dakota Department of Health, we've developed this follow-up program for people that are at risk of suicide. One thing that we really wanted to emphasize here is that networking and those good relationships with your Department of Health, just because when you get those people on board and you get those people behind you, it's a lot easier to get programs like this up and running, and that support is really helpful from other agencies and that sort of thing as well. So program referrals come from hospitals and clinics all across the state of North Dakota. We do have a list of them coming up, so I'm not going to go through all of those right now, but we also refer people internally when they call the 211 helpline or the National Suicide Prevention Lifeline. So the primary goals of the follow-up program to ensure the physical and emotional safety of the participants, empower and motivate the participants to use the resources that are available to them within their communities, and then to reduce service gaps by promoting the continuity of care. And then here's that list that I mentioned earlier of the hospitals and clinics that we're currently partnering with. So we receive external referrals from these. Usually they just fax us the sheet of information that has like the client's name, phone number, that sort of thing, so we can get a hold of them. So. Okay, so the follow-up care can be a variety of different things. Our center, what we normally do, it's mostly phone calls, but we do some letters and the caring, which I will talk about those a little bit later as well. So it's basically the follow-up is designed to check in with those individuals that we've received those referrals for, to see how they've been doing since they've been discharged, see if they have any suicidal thoughts, actions since they've been discharged, that sort of thing. Anything that they want to talk about, we're willing to listen to them. So it's basically about having them feel like they're being supported as they continue towards their recovery. So typically when we do call them back, as the longer they're on the program, we do catch people on good days, and so the calls can be pretty brief because they aren't thinking about suicide or they don't have anything that they really want to talk about or need to talk about, but it also depends on the individual. Sometimes they can be a little longer depending on what that person is needing at that time of that call. Okay. So like I said, I mean, it definitely depends on the caller, like what kind of mood they're in, what they've been going through lately. That kind of dictates how the call will go, so that kind of influences the roles and responsibilities of that call specialist depending on what exactly they would need. But it's just a list of like general roles or responsibilities that sometimes we would usually take. It's a lot of like non-judgmental listening and support, and then doing that, risk assessment to see if they have been having any thoughts of suicide, if they have a plan, that sort of thing. So like general outlines or roles and responsibilities of the program, we attempt to reach every referral that we get within 24 hours of receiving that referral. Usually we get the faxes within 24 hours of their discharge, and that's a really important piece because that 24-hour period after people have been discharged is typically when risk for suicide spikes. So we really want to get in contact with that individual within that first 24-hour period since they've left the facility that they were in. And then, so following that initial contact with the individual. Typically, people are signed up between 7 to 8 weeks. It does depend on the individual, how often they want calls. I always like to really try and stress that, that we can call you next week, we can call you 2 weeks from now. There is kind of like a typical schedule of when we try to spread out their calls, but it depends if they feel like they need that support more often or not as well. So, and then all attempts, whether we reach the participant or not, are documented in their files. So, and that's really important as well, to keep really accurate documentation, to be really organized, to not miss calls when you're supposed to be calling people. So that's been a really big deal as well as the organizational piece of it. So here it just kind of explains that the follow-up calls are typically made once a week for the first couple weeks that they're on the program, and then after that it goes to biweekly for the third to the fifth week, and then monthly, and then so that's like a typical schedule, but it does depend again on the individual, what they feel like they need, what they want from us, or what they need from us, that sort of thing. But we do try to get their calls to be further apart from each other the longer they are in the program, because we do want to empower that individual to use the resources in their community, to know that they can always call us if they need us, but to not necessarily be dependent on that resource of us calling them as well. So before we close any files, we do try to attempt to get in contact with the individual 5 times, just so we know that we've made a valid attempt at trying to reach that person. And if we can't reach them, we'll send a letter letting them know that we've been trying to get a hold of them and we weren't able to get a hold of them, and then we close that file. So these are the caring cards that I mentioned before. There has been some research on these and how exactly they influence care after people have been discharged. It talks a lot about like getting a letter in the mail and the fact that it's handwritten, because sometimes that's not really something that happens a lot anymore. People are, on the phone or texting or email and that sort of thing. So handwritten letters have kind of not really the thing to do anymore. So I really like these. They seem to be more meaningful and more personal to callers, and when they're in that vulnerable state of being discharged, they just had their suicidal ideation or attempt, it seems like that really helps them feel like they do have somebody there that cares about them, and it makes an impact. So this slide is just talking about like the basic concept of them, and then the research behind it, and then some of the benefits. Some of the benefits of the caring cards, obviously they have a psychological impact, a positive one on the individuals, and then they're inexpensive and they don't cost a lot for call centers to do them, and we can use existing staff and resources to implement this to try and help the individuals. And then this slide is just some of the research articles based on those caring cards and how they have seemed to positively influence people after they've been discharged for suicidal ideation or attempts.
I don't think I have to convince this group that suicide is a national public health crisis. Research indicates that the follow-up with hotline callers and people recently discharged from emergency departments or inpatient settings has a positive result for both the consumers and providers of mental health services. Columbia University, under the direction of Dr. Madeline Gould, has been studying the impact and importance of follow-up services. FirstLink has had the opportunity to be part of these studies and has been in cohort 4 and now in cohort 5. Follow-up has been shown to be cost-effective and prevent suicides, and crisis centers are uniquely positioned to be a crucial resource for people in need of follow-up care. Follow-up ensures continuity of care, provides support during a time of heightened risk, and facilitates linkage to outpatient care. It fills a significant gap and acts as a safety net for those at risk of suicide. Suicide risk is the highest in the first week after discharge from an inpatient setting. This risk is 102 times higher in men and 246 times higher in women than their counterparts in the general population. As many as 70% of suicide attempters never attended their first appointment or maintained treatment for more than a few sessions. So some benefits. Follow up with patients by telephone within 1 week after an emergency department discharge for a suicide attempt significantly reduces the likelihood that the person will reattempt suicide. Patients who received follow-up have a lower suicide rate in 5 years and even a significantly lower suicide rate in the first 2 years after discharge. We are encouraging hospitals to participate in FirstLink's follow-up program. We talked to them about the study completed by the Truman Health Analytics. Truman estimated the amount of savings by reviewing data from crisis center costs of implementing follow-up calls and their potential to reduce the hospital readmissions and general emergency department visits after 30 days of discharge. Here's just the link that shows the research. Crisis helplines are uniquely positioned to provide follow-up care. They provide 24-hour access to staff trained on suicide assessment intervention. They are already assessing for risk of suicide. They provide support, offer referrals, develop a safety plan. We have the ability to dispatch emergency interventions when necessary. We can intervene when a caller is not or able to ensure his or her own safety. There's a 30-minute training module that demonstrates structured follow-up and monitoring. And then if you haven't used the My3 app yet, I'd put it on your phone and just play around with it. It's an easy app to use and for callers, and it's free too. Really nice resource. So where to start? Where to start in our crisis centers? We want to set guidelines for enrollment criteria. So like FirstLink offers follow-up program to our callers that have moderate or high risk of lethality. It's important to train crisis center staff to recognize and refer callers to the follow-up program. Start small and expand the program once staff is comfortable with procedures and enrollment criteria. For example, we recently signed an MOU to work with a large local hospital in our area. We did not want to be overwhelmed with referrals. They had no idea how many referrals that they're going to be sending us. So we just decided to start in one department. We started with the ED, and then later we're going to wait a few weeks, see how many referrals we get from the ED, and then expand it to the inpatient treatment units for referrals. Engaging healthcare facilities. I originally thought that when I called a healthcare facility and told them about our great suicide follow-up program, they would just sign our MOU that day. This is not always the case. We're finding they're worried about HIPAA violations, their own facility policies and procedures. So to start working with some facilities might take some time. Be persistent If the first contact's not interested, try a different job position in the same facility. Talk to staff working with direct patient care. These are the staff that have been working closely with these patients, and they are worried about these patients. They see firsthand the need for follow-up programs. You can convince some of the floor nurses that the program is good, then they'll work their way up higher and get management approval. At other times, we did contact with hospital administration first, and then we talk about the return of investment, because of course the administrator is concerned with budgeting and finances. We also talk to social workers, nurses. Find out who completes the discharge paperwork for the patients. These are valuable people because they'll probably be the people that are making the referrals to you. So you want a good relationship with the discharge providers. Once the connection's made, establish a designated contact person. We like a primary and a secondary contact person. We like their phone number and their email address so we can contact them and keep the line of communications open. So to continue your partnerships with the hospitals, we think it's important to train or meet, educate on the program face-to-face. If the hospital sees you face-to-face, they're more likely to remember to ask their patients for referrals. After you first train a hospital and they sign an MOU and they get on board, it seems like we get a lot of referrals pretty consistently for a while, but then those referrals taper off. So it's really important to have regular meetings, phone calls, emails with these healthcare providers. If we're not getting referrals from them, just to give them a quick phone call or a quick email to remind them, to be making referrals and be screening their patients for suicide thoughts. Some hospitals, we actually do a quick weekly call that we have scheduled. Some we meet with monthly. Provide materials to the hospital, forms, handouts, posters, anything that might make it easier for the hospital to make referrals. An example is we give the hospital the script for the nurses can read to the patients. I think this is important for if there's like floating or transfer nurses that only work on the floor for one day. They can just pull that script off, read it right to the patient, and know a little bit about our program and get the referrals for us if the people are having suicidal thoughts. Very important, make sure the patient information is on the referral form is legible. We recommend attaching a patient label or sticker to the fax that you get in. Just with the faxes or people's different handwriting, it's sometimes hard to read their names, so it's really, that patient label made it just so much easier. And also we have to stress to the hospitals to include the phone number. Once in a while we'll get a referral without a phone number, and of course we do phone service, so we really need that phone number. And that brings us back to the continuing partnerships with hospitals. If a nurse forgot a phone number, it's nice to be able to call the social worker. They recognize who we are, so they're able to give that phone number to us over the phone and feel comfortable to release that to us. We do some individualized services to meet their goals. For an example, we do some personal referral forms. So maybe some hospitals want their letterhead on the forms. And some hospitals want outcomes, and some want no outcomes. Some just want to know if we contacted that person, and we just fax them that we contacted them. Some want a pretty detailed report back. So we work with hospitals individually and try to make that happen for them. So things that also helped us get going in our follow-up program, work with the Department of Health and Human Services. I know we have a really good relationship with them. They're good supporters of FirstLink, so it's important to work together. If you can, join your state's suicide prevention coalition if you have not already. Like North Dakota was in the process of writing their new suicide prevention, so we got the follow-up program, or suicide follow-up program, written right into the state suicide prevention coalition now. Contact the hospital association in your area. We contacted ours and they let us do a presentation, a webinar for all the hospitals in North Dakota at the same time. So great way for the hospitals to get to know us. They're also letting us publish articles in their newsletter now. They invited us to participate in their conference, and we get to have a booth at their conference. So just a great way to meet the hospitals in your area. We work with human service centers. We join with our public health. So we work with all the public health throughout North Dakota, all the clinics. And then if there's like health or mental health committees in your area, they're really important to join too. We're in some like rethink mental health communities, and it's just full of hospital personnel, schools, and just to get your name out there so they know what you're doing in your programs. Connecting to your callers, I think we mentioned this before, we contact all our referrals within 24 hours of receiving that referral. We try to contact them all 5 times. Build empathetic rapport with the participation, show concern, accommodate follow-up programs to fit their needs. So this might be, contacting them on a Saturday, before working hours, after working hours. So if they can only have a call at 7 p.m. on that night, it's important that we can do that for them. One thing that we find helpful is on the referral, there's a box that they can check if we can leave a voice message or not. That's really helpful to get a hold of the callers. Everybody doesn't like to answer their phone if it's an unknown phone number to them. So it's nice when we can leave a voice message for them. We develop safety plans that we can email out to our contacts. We do the caring cards. So if you have any more questions or additional information, Jackie Olson's the suicide follow-up program coordinator here at First Link.
And we're gonna, if you guys are ready to hand it over to Caitlin, we can do that, and then we can address any, because it looks like we have a bunch of really good questions, and I kind of want to wait until Caitlin is over or done so that we can address all of them at the same time, if you're okay with that.
Sounds good.
Great. Caitlin, you're up.
All right, thank you. So my name is Caitlin Peterson, and I'm the coordinator for best practices in care transitions and disaster mental health at the Lifeline. I first really want to say thank you to First Link for presenting on the wonderful work you all are doing with your follow-up program, and I'm really excited to be presenting with you on this webinar. Today I am going to be talking to you all about the recently issued Lifeline microsite Follow-Up Matters. And as you have hopefully seen in the Lifeline announcements and various posts we've made, as I said, we recently launched it, and I'd like to touch on the features of the site today to give you a broad overview, encourage you to take a look yourself, and also invite you to provide feedback or ask questions as needed. So here on the top of the slide, I just put the site address and wanted to show you that when you first enter the site, you're going to see some impactful and informational statistics about follow-up and its effectiveness, as well as an introduction to the vital role that crisis lines play in this initiative. So as you can see, as of our most recent network survey, over 90% of network centers in the Lifeline are providing follow-up services of one kind or another, and an additional nearly 40% have a formal relationship with their local emergency department. So the purpose of the site, as you see here and as we're discussing today, is to make finding necessary information about follow-up easier to locate, easier to share, and easier to update. Follow-up programs can have a big impact on those at risk of suicide, as well as the systems that work with folks to support them through the suicidal crisis. However, getting started with these programs and partnerships can be challenging, and the microsite seeks not to just explain why follow-up is useful and impactful, but to also put helpful tools into the hands of those who want to start these programs and embark on these partnerships. The site evolved from the Lifeline issued ED toolkit due to the necessity for, as I said, an easy to update and easily accessible resource that supports follow-up and includes partnerships between Lifeline network crisis centers and emergency departments. And the site itself provides information on getting started with a follow-up partnership, access to research and statistics that support follow-up initiatives and programs, and partnering with crisis centers, tools for providing follow-up and ways in which crisis centers can follow up with patients, a crisis center locator for EDs and other organizations to utilize to find you all at the crisis centers and to start a partnership, and there's more. I really can't encourage you enough to take a look. So as we go into the site, the first section is going to give you information on follow-up care and an introduction into what follow-up is and why it's a necessary service. This section touches on the challenges that many patients face after being discharged from the hospital, such as a lack of attendance or engagement with outpatient providers, gaps in available care, long wait times, or simply not being aware of the various services that exist in systems that can be difficult and complicated to navigate during the best of times. Some patients being discharged from the ED lack a social support network, and having someone from the crisis line contact them to check in can help reduce feelings of isolation. And as we get more data and get more stories from people who have participated in the follow-up programs, oftentimes participants are voicing feeling cared about, which is incredibly important. And of course, we know from the diversity of crisis center services, practices, and communities served that follow-up isn't just one thing. It can describe a variety of services, like First Link just presented on, that vary from in-person contact to at-risk clients or patients receiving caring letters in the mail. It can take the form of a text message or an email, as well as phone calls, and it can be short-term, long-term, or customized to the person at risk and their needs. The section also summarizes in short why crisis lines are uniquely qualified, again, as First Link covered, to provide follow-up services and are a natural choice as a partner in systems that are trying to better align with best practices and trends in healthcare that that improve care transitions. And finally, this section provides some tools and information on the steps of follow-up, so programs don't have to start from the ground up in designing and getting started with a follow-up program or partnership. And our next section here is for emergency departments. And as with crisis centers, in emergency departments, there are many initiatives that would be good to do for and with patients to improve outcomes. And because of a variety of factors, we often have to choose just which initiatives to engage in and need to decide priorities, resources available, and proven and potential outcomes. This page speaks to that specifically for emergency departments by providing an overview of information that is vital to their decision-making process. This page also shows how follow-up aligns with current trends in healthcare, such as the National Strategy for Suicide Prevention, Zero Suicide, and the Affordable Care Act. And while the future of the ACA is uncertain, it's still really important to show that follow-up initiatives fit within that framework as a practice that is effective and can meet the goals and requirements that are laid out within. And while we at Crisis Lines need to consider the resources we have at hand and our ability to maintain the initiatives we undertake, so too do EDs and hospital systems need to evaluate the cost effectiveness of new initiatives and their bottom line. And as First Link discussed in their presentation, the site features a section on return on investment and the Truman Study that was undertaken to evaluate the return on investment for post-discharge follow-up calls. This can be really compelling information for hospital systems regarding whether engaging in a follow-up partnership will work for their setting and to generate buy-in from stakeholders. There's also a link to the study referenced on the site as well. And then the next section on the Follow-Up Matters website shares essential elements of follow-up partnerships, such as creating clear criteria for enrollment, establishing program protocols, and describing protocols and gaining consent. And it discusses that many crisis centers have taken the lead in providing follow-up services. It also shares examples of formal agreements, and that can be really helpful in getting started and modeling agreements between crisis centers and other organizations. It is also going to share various ways that crisis centers can support emergency departments in providing care to those at risk of suicide, And again, First Link talked a lot about this, and it includes providing materials, training staff in suicide risk assessment, providing aftercare, and then, of course, scheduling follow-up. And it also provides helpful resources. Some of them, but not all of them, can be customized and adapted to suit the needs of the partnership and follow-up program. And they include training resources, a sample consent form, and then information on the My3 app. And, of course, at the bottom, since this is all about starting a partnership, is a link to a map that can help those viewing the site locate a Lifeline Network crisis center nearby them. And then, of course, this section is titled, is going to provide the user access to a wide variety of resources that support follow-up. And they can go a long way towards, quote-unquote, making the case for follow-up in an in-depth and research-based way that can be very meaningful for stakeholders. And it's especially important because this is often the information that stakeholders need to generate buy-in for follow-up and partnering with crisis centers. And it's an incredible time saver so that you and emergency departments don't have to do all the legwork in locating the information. And then the last section on the website that I'm going to discuss today includes, of course, the map that I discussed to help people locate their nearest crisis center, and provides those looking at the site the website to the crisis center. So if you're a crisis center on the webinar, I would really encourage you to check it out, and please let me know if it needs updating. And then you're also going to see here some stories of hope, including reasons to call and easy to locate and view statistics related to the benefits of follow-up. And then, of course, an About Us section that will introduce the viewer to the Lifeline leadership team and some background information on the Lifeline. And then lastly, I just really wanted to talk about how the Follow-Up Matters website can benefit crisis centers. And I've covered most of it already, but I really just want to emphasize that it can help you find and share information, including research and statistics that backs up starting or expanding your follow-up program to stakeholders, helps folks outside of the crisis center learn about the various methods of providing follow-up, and can also give you some ideas on how you might like to expand your follow-up program that you've already established. It provides a quick and detailed resource for you to pass on to potential partner organizations with whom you'd like to start a follow-up partnership, or who may reach out to you for more information about crisis centers and their role in providing follow-up. And again, as I stated, it really does save time and resources by organizing and presenting the materials all in one place. And I just, as I end here, I would really like to say that we're really excited to share the site, and again, encourage you to use it and share it and let us know your feedback. Thank you. I really hope you'll check out the site.
Thank you very much, Caitlin. Do you have a way for people to get a hold of you if they do want to send you questions or feedback?
Sure. My email address, which I meant to put on a slide here, and I apologize that I forgot about that, is cpeterson@mhaofnyc.org.
Great. Thank you, Caitlin. Thank you, Jennifer, Cindy, and Jackie. The information so far has been really great, and I know, just kind of following through the chat here, that people are definitely interested in the programs that are out there, the programs that are very successful, the research that's been presented, and hopefully people will find the new microsite beneficial. And while we're talking about kind of sharing resources and information and knowledge, I did want to quickly plug the Lifeline Network Center's Facebook group. This is a really great place for people to share information, ask questions about follow-up programs, about other types of programs, about staffing, about whatever they feel like they want to put out into the network to share feedback and questions with. And you can email me at cmaxwell@mhaofnyc.org, and I can link you into that Facebook group, or you can find it at facebook.com, and I think it's / let me pull it up actually, just to make sure that I have it right. I don't want to tell everybody the wrong one. It's facebook.com/groups/Lifeline Network Centers, and you can ask to join through that. So now that I got that plug out of the way, I want to get to all of the questions that we had in the chat group, and we had a lot of really good ones. And these are for the first link, folks. Can you, and the first question was about elaborating on collaboration with the State Department of Health. Can you tell us a little bit about what those initial conversations were like, and how that's benefited the program overall?
Yeah, it's been a huge benefit for the program. So we started meeting when we called them up to see who we could meet with to discuss our program and to make sure that they know who we are and what we're doing. We got new staff into the State Department, and so that piece hadn't continued from people that were there before, and we weren't part of their plan before. And so just making appointments, meeting face-to-face, talking to them about who we are, what we do, and then trying to see how we can work together, because obviously they also want to be able to decrease rates in the state. And so met with them, started talking about ways that we can work together, how we could help them, how they could help us. Lots and lots of collaboration with trainings. We found a certain area of the state needed extra support. They would contract us to be able to go there and do trainings. So it just got to be where they knew us more and more all the time and started thinking of us whenever they had a need in the state. And just growing on that relationship. So now, we're a big part of their the coalition's state plan, and right now they're looking at writing more grants to try to help support us. So I can't say enough about meeting with them regularly.
That's tremendous. And to receive that level of support had to have been so helpful.
Yes, it really was.
Yeah, great. So the next question we had come through is, this is about means of contact. Are all the contacts that the follow-up contacts that you guys do, are those by phone, or do you use other methods?
Yeah, usually all of our contacts are by phone. We don't do anything face-to-face, but that's the nice thing about our database and the resources that we have access to is if that individual is requesting like a support group or wants to do peer-to-peer networking to get in contact with somebody that they can meet face-to-face, that they have gone through similar things. We always look in our database and we can give that individual that information and that referral. We do have an email address specifically for the program. So if for some reason the individual wants like a resource like emailed to them or something like that, we don't have to use our personal emails. We can send it via that prevention email, and then that way if they have other questions or want to email that email address back, they can. But then we do the letters and the caring cards as well. But most of it, a good majority of it is phone-based. So.
Great. Do you bill Medicaid at all?
No, we don't. Currently, we have the SAMHSA grant right now, and then we're getting support that's going to be starting now with the Department of Health. But at the moment, we do not bill at all. But we've been really transparent with the hospital associations, telling them that down the road, if this continues to grow like it is, there will be a need for them to be able to help support us. And so some of them who are using us more regularly are starting to make donations to us on a regular basis. So that's the extra funding that we're getting at the moment. But nothing is being billed.
Wow, that's really cool, and those donations can really speak to how much the program is really helping those people.
Yeah.
And to answer part of that question, I know that there are centers out there who do bill some of these follow-up services to Medicaid. Caitlin, are you aware of any that might follow that kind of model?
Not off the top of my head, but I think that there's definitely a movement as, crisis centers talk about their programs expanding and needing the resources. And this is obviously something that I can look into in more detail and follow up with people if they're interested.
Okay, great. Do we know if we have any resources like that on the Matters site at this point?
I missed what you said there.
It was a question for Caitlin. Do we know if we have any follow-up Matters resources regarding Medicaid billing or any templates for creating that kind of program or anything like that?
We don't have templates, but what we do have, as I said, there's a page that's specifically regarding the EDs that does show how it aligns with a lot of different initiatives that can help lead towards being able to bill for these services. So I think it's definitely something, like I said, worth looking into more and finding a way for it to be for that to happen, because the services are impactful and useful, and as we saw, they do provide a return on investment.
Cool. So we may not have something very specific to Medicaid, but we do have pieces of creating a model similar to that, and to be able to kind of look at some of the components that are involved. So that's good. Cindy, another question that came up: how do you all keep record of the handwritten notes that end up going out, the caring contact letters?
Yeah, I actually wanted to clarify that question. Was it, because we keep track of it, like when we send the caring card out to the individual, we write that in their file, and then we have like a specific calendar for it, and we just mark like a tally to keep track of all the ones that we send like in a month. So like, was it keeping track of how we send them to each individual, or I guess, did that answer the question, or do you keep a copy of the actual card?
Yeah, that seems to make sense. I think it looks like she's responding. Yeah.
No, we don't keep a copy of the actual card in their file, just because
We just make an entry that the card was sent out.
yeah, we just, I don't know, we've never really thought that that was necessary, I guess. So we handwrite them, mail them out, and then mark in their file that so.
All right. The next question is regarding concerns around protection and confidentiality. Do you have people sign up for the follow-up letter as part of the consent form when they're enrolling in the program? What sort of protections and confidentiality steps are put in place when those caring contact letters get sent out? And the person that asked this question specifically was asking in case somebody else in the household received that letter and they may not have, that wasn't actually supposed to get to them.
Sure. When we work with the hospitals and train them on how to give referrals to us, who's appropriate to refer to us, we give the hospital staff a script, and in that script it says, when you join the follow-up program, you'll receive phone calls, caring card in the mail, and then they fill out their own name and address on the form, and then they sign the form. So it's just kind of it's a verbal agreement that the nurse tells them before they sign the referral paperwork.
And also, it's a really plain, it doesn't say suicide follow-up call program all over the front of it. Obviously it's very, nondescript kind of envelope that's coming there too.
Mm-hmm.
Right. Right, and so they know when they're signing up for the program, they are given appropriate expectations. They know that it's going to come in the mail, so that that's not a surprise.
Yep. When we do internal referrals, especially we specifically ask for their address. We do get callers sometimes that are like, well, why do you need my address? And they're like, well, we just, we send you like a caring card, just a handwritten note, saying that, welcome to the program, that sort of thing. It's like an introductory thing, and then that closing letter, and that's all we send them. Like, we don't send them like junk mail or anything else about stuff that they wouldn't care about. It's really only the 2 letters that we do send them. So once we explain that, most people are like, oh, okay, and then they give us their address, or if they don't want it, they don't give us their address. So.
All right, and that kind of leads into the next question about how many contacts on average, percentage-wise, are you able to connect with after they, technically enroll in the program?
Yeah, I saw that question, and I knew it was going to be a tough one because I can't give you an exact number off the top of my head. It doesn't happen very often, though, where after those 5 attempts at contacting them, we don't get a hold of them. It does happen, though. I mean, phone numbers get disconnected or numbers change, that sort of thing. And that's why, we do send those letters. It's also important to, when we get those referrals, to have on the referral sheet what is the best time of day for us to try and get in contact with that individual, and if we can leave a voicemail or not. That permission, that consent to leave a voicemail is really important because typically people don't answer phone numbers that they don't know. So if we leave that voicemail initially and then they're like, oh, okay, and then they know it's us, and then when we call again, they recognize that phone number, and then we can get in contact with them. We do have, I know Jennifer mentioned it briefly about the outcome reports. So sometimes when we can't we try those 5 attempts, can't get a hold of that person, we'll fax that back to the clinic, and then they have their own follow-up procedure that they follow through with if we can't get in contact with them 5 times, so, or within the 5 attempts. So,
Great.
It's not a lot. It's not very high that we don't end up getting in some sort of contact with the person. So.
Right, and that really speaks to how important it is to have appropriate training for the hospital staff in filling out that information and communicating what those expectations are going to be.
Yeah, absolutely.
Cool. So the next question is there an age range or requirement when it comes to follow-up services?
We take anybody on the program. We get referrals from all ages, but we need, if we're doing an internal referral, we need parental consent for anyone under the age of 14. For external referrals, typically if people are under the age of 14 or under the age of 17, the clinic or hospital gets that parental consent. But if you're under the age of 14 and it's just an internal referral, like if they call us and we ask them about the program, we don't need that consent if they're 14 to 17 from parents to be able to contact them. So.
The State Department of Health helped us set up those guidelines back when they helped us start the program back when.
That's excellent to know that you were able to collaborate and communicate with other entities to double check on what the procedures might look like for that.
Right.
Yeah.
Cool. The last question that we have, and I think we have just enough time maybe to talk about this, is do you have any tips or resources on, and this can go out to Caitlin too if she knows, but formulating a cost structure to provide estimates to hospitals, inpatient programs, or insurance companies?
I don't not believe that we do. I don't know if Caitlin does.
What sort of things were involved when you were looking at setting up those cost structures or initial proposals for the first couple hospitals that you were working with?
We're not charging any hospitals currently at the moment. Some are just making donations to us, and but nobody's being billed per se. You know. So
Right. Okay.
So we do not have a schedule. I know we wrote to James Wright and to Madeline Gould when we first, as more and more hospitals are adding on, we're nervous about what happens when we need to have more help support the program. And yeah, they said that they didn't have a lot of other people that had a program in place right now either with, we thought, we don't want to reinvent the wheel. So if someone's already got a program in place on how to bill or how to charge or, depending on how many referrals each hospital makes, how would that look and what would the cost be for them to help support the program. But we've not had to do that yet because we do have a SAMHSA grant at the moment that's helping us with the program. Yeah.
Right.
But if someone else has a great idea, we would love to hear about it.
Mm-hmm.
Yes.
Absolutely. Okay. Well, we are right at 3 o'clock. And again, I just wanted to extend our utmost thanks to Cindy and Jennifer and Jackie and all the work that First Link is doing regarding follow-up. It sounds like your program is excellent and stellar and is definitely a life-saving program, so we appreciate that. And thank you, everybody, for joining in. Thank you, Caitlin, for talking about Follow-Up Matters. Again, if anybody needs to send us additional questions, you can reach out to Caitlin at cpeterson@mhaofnyc.org or myself at cmaxwell@mhaofnyc.org. And
Chris?
other than that, we're good to go.
Yeah, Chris, we're going to be at the AAS conference and at the AIRS conference, so if anyone wants to meet with us sometime, just to know that we'll be there, too, if they have more questions.
Great. Yes, definitely. Everybody keep an eye out.
Okay. Thank you.
Thank you.
Thanks, everybody.